So, good evening, all the aspirants present here. We'll be continuing with the cardiology domain, and the speaker that we have here is Manidipa Majumder, ma'am. Yes, ma'am, you can take over. Thank you.
Good evening, everyone. So, I'll be starting with the remaining part of our session two, in which initially we studied about heart failures, and we will be studying today about cardiomyopathies, and into session three, which is about acute coronary syndrome and some pericardial disease pointers. Okay. So, cardiomyopathies, as you all know, cardiomyopathies are diseases of the heart's muscle. So the main three types of cardiomyopathies that we learn in MBBS level are dilated, restrictive, and hypertrophic cardiomyopathies. But once we study more, we also learn about two more, that is the arrhythmogenic cardiomyopathy and LV non-compaction, which can present either as a dilated cardiomyopathy or as a restrictive cardiomyopathy, depending on which phase we are in. So these are the five types of phenotypic types of cardiomyopathy. There are n number of reasons. Cardiomyopathies can also be classified into primary and secondary. Primary meaning the disease process only affects heart, and secondary meaning there is a systemic disease out of which heart is also affected, in which the heart the phenotypic expression is one form of cardiomyopathy. So these are the etiological types of primary and secondary cardiomyopathies. You don't have to remember every, but go through the list once, because there are many clinical scenarios that will come, especially in MRCP2. So you need to remember in which diseases you can expect cardiomyopathy as well. Primary cardiomyopathies can be acquired, genetic, or mixed. Acquired are myocarditis, peripartum, tachycardia induced, or Takotsubo cardiomyopathy, which is also called the stress induced cardiomyopathy. Genetic common variants are arrhythmogenic right ventricular dysplasia, which is also known as the ARVD or ARVC, and hypertrophic cardiomyopathy, ion channel disorders, left ventricular non compaction, and mitochondrial myopathies. There are many others as well. Mixed are dilated and restrictive types, which can be either acquired or genetic or both. Secondary causes of cardiomyopathy, we have the autoimmune, infiltrative disorders like amyloidosis, Gaucher's, Hunter's, Hurler's. Among these, amyloidosis is quite common. Among autoimmune, the sarcoidosis is quite common, which might present as a systemic disorder or as purely as cardiac sarcoidosis. In endocrine, commonly we find cardiomyopathy in hyperthyroidism, in acromegaly, and sometimes in diabetes mellitus, but in that the effect on heart muscle is multifactorial. Infectious Chagas disease, hepatitis C, HIV can all present as cardiomyopathies, but they are rarer. Among toxic cardiomyopathy, alcoholic cardiomyopathy, and anabolic steroid use is quite common and found in regular hospital admissions as well. Nutritional deficiency, kwashiorkor, L-carnitine, niacin, selenium, thiamine, and vitamin C deficiencies we can find. So I'll move on. If somebody wants to answer, they can answer. So which murmur increases with Valsalva? We had read a little about dynamic auscultation in the first class. Anybody
So
wants to answer?
hypertrophic cardiomyopathy.
Yeah. Any other murmur do you remember? This is related to cardiomyopathy, so HCM is the correct answer, sir. Any other cause which increases with Valsalva? Can you remember? Anybody? You can write it down in the chat as well if you remember. So HCM for the first question is the correct answer. Number two, which cardiomyopathy is most commonly associated with alcohol? What kind? Which is the phenotypic type of alcoholic cardiomyopathy? Is it HCM, RCM, DCM? What is it? Non-compaction? What is it? So we have DCM. DCM, correct. So DCM is the correct answer, dilated cardiomyopathy. And which cardiomyopathy shows low voltage on ECG with thick LV walls, myocardium on echo? What is the phenotypical type and what is the probable cause? Anyone wants to take a guess? Let me check. Mhm. Nobody has answered.
Restrictive.
Yeah, it's restrictive, and the most common diagnosis in this kind of scenario is amyloidosis. And somebody has written dilapidated cardiomyopathy. I have not heard of anything like that, but that's okay. It's dilated cardiomyopathy. Well, the heart becomes dilapidated. There's some truth in that. So dilated cardiomyopathy. This is one of the most common cardiomyopathy that we encounter in clinical practice, in which we see dilatation of the LV majorly. Sometimes there is RV dilatation as well with systolic dysfunction. Causes commonly are alcoholic, chemotherapy induced, viral myocarditis, peripartum, genetic cardiomyopathies, and idiopathic. The most common two variants are alcohol and viral myocarditis, and your MRCP2 clinical scenarios will mostly come from that, and also peripartum, of course. Clinical features include fatigue, dyspnea, and signs of heart failure. Complications can be atrial fibrillation because of atrial enlargement, ventricular arrhythmias due to ventricular muscular dysfunctions, thromboembolism, and sudden cardiac death. Thromboembolism because LV becomes very weak and there is stasis of blood in the left ventricle, which forms blood clots in the ventricle, which results in systemic thromboembolism. May include stroke as well. Stroke, sudden coronary occlusion, or occlusion of the vessels of the leg. Anything can happen. Investigation ECG is non-specific, which may show AF, LBBB, or poor RF progression. LBBB, see any kind of bundle branch block or intraventricular conduction delays are markers of abnormalities of repolarization or depolarization. So the muscles get stretched, they are not working very well. It is taking very long for the heart muscles to be depolarized. So LBBB, RBBB, poor RV progression, these are markers of LV dysfunction. Chest X-ray will show cardiomegaly and pulmonary congestion in case of failure. Echo, we will see dilated chambers with reduced ejection fraction. Management is standard heart failure therapy. Yes, if the ejection fraction is less than 35%, ICD is indicated, and sometimes CRT is indicated. We read about CRT indication, cardiac resynchronization therapy indication, in the last class. If anybody remembers, please write it down in the chat. I will see. Remember the CRT indications in heart failure. And of course, the definitive therapy of DCM in terminal stages is heart transplant, where nothing works. Okay. Takotsubo or stress cardiomyopathy is a favorite of MRCP questions. It is an acute reversible LV dysfunction triggered by emotional or physical stress. There is a catecholamine surge due to this stress, which causes myocardial stunning. So, what is stunned myocardium? The cells, the myocardial cells that are not contracting, but these are not dead. They're metabolizing. So they are taking up nutrients, they're taking up blood and oxygen, but they are not pumping. So this is called myocardial stunning that occurs in the initial phases of ischemia as well. So there is myocardial stunning due to catecholamine surge, which causes LV dysfunction in acute setup. The name is derived from octopus or fish catching basket. It's a Japanese word. Classical finding is apical ballooning that is seen in echo as well as in angiography. If we do an LV angiography, we can see clinical features. It mimics acute MI. There is mostly chest pain. It's not like cardiomyopathy, which presents as breathlessness. It presents as MI. Chest pain, ST elevation, troponin rise. Coronary angiogram will be normal. Echo will show apical ballooning and hyperkinetic basal segments. Cardiac MRI we can do, which excludes myocarditis. In cardiac MRI of Takotsubo, there won't be any infiltrates or any edema or any inflammation seen, unlike myocarditis, which will be positive in cardiac MRI. Management is supportive, mostly heart failure therapies. Recovery usually within weeks, but not, remember that not all patients recover. Mostly they recover, but it is not 100% recovery is not there. Complications are arrhythmias, LV thrombus, and shock. So this is typical Takotsubo cardiomyopathy, where you can see this is the left ventricular cavity. In the last class, we will take some basic, I'll give you some basic tips and tricks about interpreting echoes. Echo images are rare, but they may come in MRCP part 2. So remember, this is the apical four-chamber view in which we see all four chambers of the heart. And in here, we can see the LV. This is the apex of the LV. It becomes ballooned out, and you can see this is the ECG, typical ECG of um, Takotsubo cardiomyopathy. This can very well be an interval MI as well. There is frank ST elevations in the anterior leads. So, what is the clinical criteria? Mayo clinical criteria that can come as an MCQ, especially in MRCP part 1. These are the four criteria: LV regional wall motion abnormality, absence of coronary lesion, ECG abnormalities or increase in troponin levels, and absence of pheochromocytoma or myocarditis. Why pheochromocytoma? Because then there is a cause of catecholamiine surge. In Takotsubo, there is no organic cause. There is always psychological or traumatic, post-surgery or emotional stress are the causes. Diagnostic hints are this: ST elevation, T wave inversion, increase in cardiac enzyme levels, decrease in ejection fraction, and close prior stressful event history, and faster recovery than other cardiomyopathies. Now coming to peripartum cardiomyopathy, very important for all kinds of MCQ, including MRCP exams. Peripartum cardiomyopathy presents as dilated cardiomyopathy occurring in last month of pregnancy till 5 months postpartum. This definition was different before. Now it is less than equal to 5 months postpartum from last month of pregnancy. Risk factors are multiparity, age more than 30, like elderly primary gravida, preeclampsia, patients with hypertension, obesity, African descent, that is, black race people will have more chances of having peripartum cardiomyopathy. It is quite surprisingly very common in India as well. Clinical features include heart failure symptoms like dyspnea, orthopnea, and edema. Echo will show typical DCM, dilated LV, and reduced EF. Only from the history, you can guess it's a peripartum cardiomyopathy. Management is standard heart failure therapy. Standard heart failure therapy. Anticoagulation if EF is very low. This is one of the exceptions of the CHA2DS2-VAS score. In peripartum cardiomyopathy, if AF is present, you don't need to do a CHA2DS2-VAS score. You directly go for anticoagulation. Bromocriptine has been found useful in some isolated studies, but it has not yet been included in guidelines. Please go back and read about the pathophysiology of peripartum cardiomyopathy. It's fascinating. There are many theories, one of which includes a prolactin-like segment circulating in the blood, which is why we come to the bromocriptine thing. So we do not have time to explain it, but please do go back and read the pathophysiology. 50% of the patients recover completely, others progress to chronic heart failure. High risk of recurrence with future pregnancy, so contraception needs to be advised. Peripartum, this is a summary of peripartum cardiomyopathy. By definition, the EF has to be less than 45% and presents commonly in the first months of postpartum or towards the end of pregnancy. During pregnancy, we give beta blockers, loop diuretics. We know that ACEI and ARBs and aldosterone receptor antagonists are contraindicated. Mechanical MCS is mechanical circulatory system. For severe heart failure or cardiogenic shock, consider early delivery if unstable. Delivery, plan ahead with cardio obstetric team. Mostly patients, babies are delivered by cesarean section, but it varies from country to country. There is no fixed guideline on that. After pregnancy, anticoagulation, heart failure management, and discussing contraception. This I wanted to show you the causes of reversible cardiomyopathy. Okay, a patient came with cardiomyopathy and failure, but you can assure the patient that if you follow certain rules, there is a high chance that your LV function or the heart pumping function will come back. So, what are the causes? Myocarditis, partially reversible. Some patients get better, some don't. Sepsis induced, many people get better if the patient comes out of sepsis over a few days or weeks, the LV function will improve. Alcoholic cardiomyopathy is also largely reversible. Peripartum, 50% reversible. Stress induced is mostly reversible. Tachycardia induced cardiomyopathy, if you treat the tachycardia well, the cardiomyopathy, the LV function will come back. Thyroid disease induced, especially in cases of thyrotoxicosis and hypoventilation related. And toxic, as you can understand, toxic is also partially reversible, not completely reversible. Now, coming to the second phenotype, that is restrictive cardiomyopathy. By definition, restrictive cardiomyopathy means impaired ventricular filling due to stiff myocardium with preserved systolic function. These patients will come with heart failure symptoms, but when you do echo, the ejection fraction will be normal. What happens is the diastolic dysfunction. In this kind of patients, most of the clinical features will be of right sided heart failure signs, because impaired filling, which is the main filling chamber, our right side, right? The right atrium and the right ventricle, they collect all the blood from the venous system. So when there is increase impaired filling of the ventricles, there will be increase in the systemic venous pressure, which will lead to increased high JVP, hepatomegaly, and ascites. There will be exercise intolerance and fatigue. Dyspnea, frank dyspnea, pulmonary edema, which are signs of left heart failure, are rare in restrictive cardiomyopathy. Causes are infiltrative, like amyloidosis, sarcoidosis, hemochromatosis. Questions can come from any three, all three are quite important, or fibrotic lesions like radiation or scleroderma. Complications are mostly arrhythmia and thromboembolism. They are very highly prone to develop AF, atrial fibrillation, and hence thromboembolism. ECG shows low voltage complexes and there can be conduction abnormalities. Anything that messes up with the cardiac muscle can have conduction abnormalities. Okay. Echo, these are typical findings of restrictive cardiomyopathy. So in MRCP part 2, they will give you these clues. There is biatrial enlargement, normal or smaller ventricles, restrictive filling pattern in the echo Doppler, and sometimes there will be a thickening of the interatrial septum. Okay, there will be AF that can be detected either in ECG or echo. Cardiac MRI is almost always diagnostic, which will show infiltration or fibrosis. Management is treating the cause. There is no particular therapy, especially for restrictive cardiomyopathy. Chelation for hemochromatosis, immunosuppression for sarcoidosis, and transplant in selected cases. Remember, this is not DCM, so you cannot use ICDs or CRTs to improve function because EF remains normal. Coming to cardiac sarcoidosis, there is granulomatous infiltration of the myocardium and is often part of a systemic sarcoidosis but can be isolated as well. Pathophysiology, there are conduction abnormalities, arrhythmias, and restrictive physiology. So, in MCQs, the clinical pattern will be a patient will say with say lymphadenopathy or chronic cough, or what one very common clinical features favorite of MRCP that comes for sarcoidosis, one skin change. Can anybody tell? Somebody can write down in the chat, or anyone. Can anyone tell what is the typical skin change, very common skin change in sarcoidosis that comes?
Erythema nodosum.
Very good, Dr. Deepak. Yeah. So
Oh,
erythema nodosum means in MRCP questions, always think of sarcoidosis first. Okay. So cardiac MRI or PET, late gadolinium enhancement, FDG uptake, endomyocardial biopsy. There will be non-caseating granulomas. This has low sensitivity because sarcoidosis affects the muscles in a patchy way. So when we go inside for endomyocardial biopsy, we do not really know from either whether we are taking biopsy from a normal tissue or from the affected tissue. Management, corticosteroids is the mainstay. If there is arrhythmia, antiarrhythmics. If there is AF, then anticoagulation. Pacemaker or ICD for arrhythmias or AV block, not for LV function. Like not for that 35% criteria that we apply in DCM. Here it is for arrhythmias or pacemakers for AV block. What kind of arrhythmia is common in sarcoidosis? There can be any kind of arrhythmia, but tachyarrhythmia, the commonest is monomorphic ventricular tachycardias. Monomorphic ventricular tachycardias. AV block is also quite common. Rest of it is heart failure management. So, if a young patient with AV block, systemic sarcoid features, then think of cardiac sarcoidosis. So these are the systemic features of sarcoidosis. Is very important for your rheumatopart, for your neuro. It can be neurosarcoid question. It can be anything. So these are the systemic features of sarcoidosis. I have included these charts and tables so that when you revise through from the slides, you can remember every time, like fever and malaise, uveitis, cough and dyspnea, generalized lymphadenopathy, erythema nodosum, etc. Okay, and also please read about the pulmonary changes in sarcoidosis. It's not my domain, but it's a very commonly asked question. That's CADing classification. Panda sign is gallium-67 uptake of head and neck in sarcoid in actively inflammatory tissues. This is your X-ray of sarcoid. You can see there is diffuse reticulonodular infiltrates in the lung, and there is enlargement of the hilum. This is hilar lymphadenopathy, especially visible on this side, on the left side. This is your panda sign. See, this is a gallium-67 uptake. The face looks like a panda. This is also called the lambda sign. Okay, and these are your MRI, the cardiac MRI, FDG PET uptake, and PET MR uptake seen in sarcoidosis. The most typical is this first one, the focal septal. If they mention in MRI, we can see focal septal FDG uptake or focal septal late only septal or patchy late gadolinium enhancement, then go for cardiac sarcoidosis. Cardiac amyloidosis is the next most famous restrictive cardiomyopathy. It is infiltrative cardiomyopathy due to amyloid protein. Two common types are AL and ATTR, light chain amyloidosis or transthyretin amyloidosis. There are other smaller types as well, but these are the two that you should know about. Pathophysiology is amyloid deposits. They get deposited in between the inside the myocardium fibrils and makes the ventricular stiff, resulting into RCM. Symptoms: there is progressive dyspnea, edema, and fatigue, and there can be syncope or angina-like chest pain. Okay, there can be systemic features of amyloidosis like nephrotic syndrome, like amyloid neuropathy, which is these are common with the AL type, light chain amyloidosis. Okay, so an elderly person comes, 80-year-old with nephrotic syndrome or neuropathy with progressive dyspnea, heart ejection fraction is normal, but patient is going into heart failure with right heart failure sign, then the diagnosis will be amyloidosis. So signs are raised JVP, hepatomegaly ascites like right heart failure. There'll be soft, quiet heart sounds, sometimes periorbital purpura, that is classical of AL amyloidosis. ECG will be low voltage QRS despite thick LV walls on echo. Echo will show speckled or granular myocardium, thickened walls, biatrial enlargement. Cardiac MRI is diagnostic. Biopsy, Congo red staining will show apple green birefringence under polarized light, like any other light chain disease in AL amyloidosis. Now, the thing is, where do you take the biopsy from? This can be an endomyocardial biopsy. That the commonest biopsy taken in amyloidosis is from where? From the tongue. Yeah, the easiest thing to biopsy is the tongue in amyloidosis. Okay, remember that. Sometimes rectal biopsies as well. I will update this slide. I will send all slides of all these three first sessions today itself to the coordinator. Management is supportive, treating heart failure. Diuretics has to be used very cautiously in restrictive cardiomyopathy, and digoxin is usually avoided. CCBs, toxicity risk. It's very difficult actually to treat restrictive cardiomyopathies. AL amyloidosis, as we can do chemotherapy because it's a plasma cell dyscrasia, right? With and plus minus autologous stem cell transplant. ATTR amyloidosis, there are drugs that are TTR stabilizers like tafamidis and RNA tafamidis acoramidis. These are TTR stabilizers. Patisiran, vutrisiran, these are RNA targeted therapies. All of these are extremely expensive. Most of the Indians cannot afford. In advanced stage, cardiac transplant is the answer. Look at this ECG. This can come, this ECG and this echo with this strain pattern. These are very famous. This can come as questions in MRCP Part 2. These are very small, low voltage ECGs, you can see. And there sometimes is pseudo infarct pattern. There will be deep S waves or QS waves in the anterior leads with poor R wave progression. Poor R wave progression means what? LV dysfunction. We had talked earlier, right? But in this patient, there is no LV dysfunction. But the ECG looks like there is LV dysfunction. There is low voltages, poor R wave progression. But when we do echo, then we see these walls are very thick. These are LV walls. These are very thick LV walls. There is slight pericardial effusion, this black border. And yeah, anybody was asking any question? Yeah, I'll continue. This is the strain pattern. Okay, apical strain is common. Okay. Next, we move on to see this is the typical pseudo infarct pattern that I was talking to you about. This is a case of amyloidosis. The previous one was low voltage complexes. This is QS waves. So they will give you this ECG and they will tell the patient has a normal ejection fraction, is very old, has very thick LV walls. Most likely diagnosis is amyloidosis. Okay. Hypertrophic cardiomyopathy, I think all of you know about it. Genetic, autosomal dominant with variable penetrance. Genes are MYBPC3 and MY87. Prevalence is 1 in 200 to 500. Most common inherited disorder. Asymmetric septal hypertrophy is the most common phenotype, but there can be other phenotypes. I am coming to it. Often with LV outflow tract obstruction. Pathophysiology is impaired diastolic filling, dynamic obstruction, and arrhythmia risk. Impaired diastolic filling, why? The LV walls are very thick, so the space inside the LV cavity is very low. So filling is less, so LV output is less. On top of that, there is hypertrophy of the septum, the LV outflow. There is obstruction of the blood flow from the LV into the aorta, so there is dynamic obstruction. And due to this huge muscle mass, there is arrhythmia risk. There can be ventricular tachycardias and as well as atrial fibrillation. Ventricular tachycardia and fibrillations are common in younger HCM patient. Atrial fibrillation is common in older HCM patient. You remember that old people have AF, that's all. You can remember. Clinical features include dyspnea, angina, syncope, exactly like which valvular disease? One valvular
Aortic,
disease.
aortic stenosis.
Aortic stenosis, correct. So this is like this mimics aortic stenosis, dyspnea, angina, syncope. Even when you open the echo, it will mimic aortic stenosis because in aortic stenosis also there is LV hypertrophy, left ventricular hypertrophy. Here also we will see that. But in that case, there is fixed obstruction to the left ventricular outflow. Here the obstruction is dynamic. So when we put the continuous wave Doppler, then we can easily understand. In continuous wave Doppler, there is a typical sign in hypertrophic cardiomyopathy. It is called the dagger sign. I'll come to it. Murmur is harsh ejection systolic murmur at LLSE, means left lower sternum border or apex, increases with Valsalva standing and increases with squatting. Somebody had given the correct answer in the beginning. The other lesion which increases with Valsalva standing is mitral valve prolapse. Always remember MVP and HCMs are always do like the dynamic auscultation are opposite to the normal valvular expectations. Okay. ECG, there is left ventricular hypertrophy, deep Q waves, and repolarization changes. Echo will show you asymmetric septal hypertrophy. SAM means systolic anterior motion of the mitral valve. This is also very pathognomic of the disease condition. Management is beta blockers and verapamil to improve filling. Avoid vasodilators. Why? Why? Anybody, if you know why to avoid vasodilators and diuretics, please write it down in the chat. Uh, so nitrate, diuretics, vasodilators, digoxin, these are avoided, which increases obstruction. They also do something else. They decrease the afterload, right? ICD, if high risk criteria will come to it. But remember, family history of SCD, syncope, massive LVH, and NSVT. NSVT means non-sustained VT. If we find non-sustained VT on their 24-hour or 48-hour Holter monitoring, that's an indication for ICD. Myectomy or alcohol septal ablation if refractory. See, these are the phenotypical types of HCM. This is the most commonest, which is called the sigmoid HCM, means there is asymmetric septal hypertrophy. The outlet portion of the septum is bulging. This is the most common. In 40 to 50% of the patients, this sigmoidal type of HCM is seen. And they are usually this gene positive, MYH or MYBP3 gene mutation positive. The next commonest is reverse curve, meaning the central part of the septum or the apical septum, it forms like a spindle, seems like a spindle. This is reverse curve HCM. The other two are apical HCM and neutral HCM. Apical HCM is very interesting because apical HCM, the ECG is very diagnostic. Very deep, long T-wave inversions are seen in apical HCM. In many doctors, medicine specialists, as well as cardiologists mistake it as an ischemic change and they undergo angiogram, and then we see the angiograms are normal. So this is a typical ECG. You can see the very tall R waves that satisfied the LVH criteria. Has everyone read the LVH left LV, LA, RA and RV enlargement criteria in ECG? You should read it. Okay, they are related to the valvular changes, valvular heart disease, and they may be asked in exams. So there is LVH and there is LV strain pattern. This is LV strain pattern. Okay, this typical downsloping of the ST segments with T inversions. LV structure, there is wall thickness, septal or posterior wall ratio. These are diagnostic criteria. Parasternal and apical views we see. These are echo changes. I was talking to you about the dagger pattern. This is the dagger pattern. Usually in aortic stenosis and everything, the color Doppler will be like this, like a parabolic. And this is like a triangle and sharp rise, sharp down in a triangular fashion and rise. This is due to dynamic LVOT obstruction. This obstruction is not at the aortic level. These are the echo features. They can be asked. You can go through it once. But remember, SAM of mitral anterior leaflet of mitral valve, dagger pattern in continuous wave Doppler, hypertrophic left ventricle with dynamic obstructions. These are the hallmarks. So this is the management guidelines for HCM. For these four things we have to remember what to do. Atrial fibrillation, again, this is one of the exceptions of CHA2DS2-VASc scoring. If there is AF, go for anticoagulation. No need to do CHA2DS2-VASc scoring. You can go for ablation as well. Also remember, ablation is not a very good treatment for AF. There is high chances of recurrence. You will go for rhythm control drugs and anticoagulation. In progressive heart failure, heart transplant is one possibility. And in progressive heart failure due to obstruction, you have to understand there are some HCM can be obstructive or non-obstructive as well. In non-obstructive, there is no role for surgical myomectomy or alcohol septal ablation. अगर ऑब्स्ट्रक्शन ही नहीं है तो उसको सेप्टम को पतला करके या छोटा करके क्या ही करेंगे. There will be no help. What we can use though is negative inotropes of myosin inhibitors. Does anyone know the name of myosin inhibitor? Any of the myosin inhibitor? Ma'am, I did not receive any of the lecture noted cardio 1 and cardio 2 and third class. I request kindly share the video recording. Video recording, I think you will get it from the class coordinator. I will ask her again. And these slides also I will mail to the coordinator so that they can send you individually on your email so that you can read it from there. You don't have to open classes every time. Okay. So, myosin inhibitor, if anybody knows the name, please write it down. Nobody wanna try? It's mavacamten. There are many. Yes, very good, Dr. Rohan. Mavacamten. There are two other names. If you can remember, that's like a brownie point. Then I will know that you are a cardiologist. But mavacamten is a very good answer. Anyway, we will move on. Sudden cardiac death prevention is the most important aspect in an HCM. If you miss it as a clinician, you're at fault. We have to risk stratify and go for ICDs for primary prevention of death. Established risk markers are cardiac arrest or sustained ventricular tachycardia, the family history of HCM and sudden death, unexplained syncope, left ventricular hypertrophy or more than 30 millimeter, NSVT on monitor, that is Holter monitoring, failure to increase BP or decrease in blood pressure with exercise. This has to be done in under very controlled circumstances. And potential risk markers are resting left ventricular outflow gradient of more than 30 millimeter, LGE involving lead gadolinium enhancement involving more than 15% of the LV mass. Here, lead gadolinium enhancement is representing the scarring of the LV and left ventricular apical aneurysm. Okay. Next, I want you to memorize this. This is a very small list. There are huge lists in Harrison and everywhere else. You don't need to remember all those, but please, please do remember this. In arrhythmogenic right ventricular dysplasia, it is the PKP2, DSG2, DSP, DSC2, and JUP genes. In amyloidosis, ATTR, it is the TTR gene, obviously, transthyretin gene, and these are the commonest mutations. In light chain disease, it's not a single mutation, it's a plasma cell dyscrasia. The commonest translocation seen is T1114 in 60% of cases. HCM, I think everybody already has memorized before. Peripartum cardiomyopathy, most common is titin gene. These are the other genes that are involved. Hemochromatosis, again, everyone knows the HFE gene, and these are the common mutations in the HFE gene. In DCM, the commonest gene involved is TTN. TTN is the same, titin gene. And these are the other ones. LMNA is the laminin gene, FLNC, MY87. So I'll ask some questions. Amount of alcohol needed for DCM. Does anyone know? Okay, we'll move on. Somebody has written something. I'm not, unfortunately. You might be fortunate, actually. It's not a very good thing sometimes to be a cardiologist. Amount of alcohol needed for DCM is 80 grams for 5 years. Now, the second question, a 45-year-old with EF 15%, recurrent heart failure admissions on maximum GDMT and no major comorbidities is referred for evaluation. What is the definitive treatment? Definitive treatment. Maximum GDMT, recurrent heart failure admissions, EF 15%. Anyone?
CRT.
No, definitive treatment is heart transplant. Heart transplant. Okay. CRT, we have, since if it is not mentioned whether LBBB is there or not, okay, what is the cause? So the definitive treatment जहाँ पे भी लिखा हो, wherever it is written, the answer will be heart transplant. Which drugs improve survival but not symptoms? Heart failure medications. Last class. It improves survival, but there is no role on symptoms. I asked you to go read the mechanism of action of the drugs.
Classes of drugs like dapagliflozin.
Dapagliflozin actually improves symptoms. You know, when we start the dapagliflozin, we reduce the diuretic dose because the SGLT2 inhibitors causes some diuresis. So not that.
Aldactone.
This ACI. Aldactone though is obviously not the answer because aldactone is a diuretic, right? In heart failure, it improves survival as well, but it definitely is a diuretic. So it improves symptoms too. ACEI do not improve symptoms. What symptom does it improve? Nothing. But it improves survival. Okay. The only symptom that it treats is some amount of BP lowering. That's not a symptom of heart failure. Intervention after GDMT for EF 30%, NYHA2, QRS duration 150 millisecond, LBBB with history of syncope and NSVT on Holter. Everything this patient has. Sometimes having non-sustained VT.
CRTD. Cardiac response therapy.
Yes, very good. It is CRT-D. D for defibrillator. This patient needs a defibrillator as well for the NSVT and syncope and needs the CRT for improvement of the function of the left ventricle. Very good. Very nice. This is for further reading. We will go to the next class or I'll talk to you about some two very important things. This is my mail ID, by the way. You can mail me for any of your suggestion, feedback, especially bad feedbacks that we want to study this and please do this, take an extra session, whatever, I will comply. So these are some extra slides I added. This is tachycardiomyopathy. Okay, how to treat tachycardiomyopathy. This is your hemochromatosis, right? What are the other clinical features that are seen in hemochromatosis? Chronic fatigue. These are typical clinical scenarios that will come in the exam. Hepatomegaly, cirrhosis, everywhere there is excess iron deposition. In liver, it causes this. In skin, this is the manifestation, white nails and all. In joint pain, there will be osteoporosis. In pancreas, there will be diabetes mellitus. There will be skin dryness or bronze coloring of the skin, right? There will be hypopituitarism and cardiac rhythm disorder. So these patients are RCM patients. If the heart is affected, then it will be restrictive cardiomyopathy type. This is your favorite ARVD. It's not very common in India. It's seen, but it is probably more common in UK. So the typical things that you need to know that it occurs in stages. The concealed stage, electrical stage is when there are ECG changes but not much symptoms, and structural stage when everything is there. There is LV dysfunction, there is RV dysfunction mainly. In some patients, there can be LV dysfunction as well. There is ECG changes, patient will have symptoms of right heart failure, patients may die, etc. etc. The typical ECG changes of ARVD is the epsilon waves. Have they drawn this? See, there is a notch in the downslope of the R wave or just near the J point. There is a notch or slight small wave. This is called the epsilon wave or epsilon seen in ARVD. This is the typical pathological finding, lots of fatty tissues in the cardiac muscle. This is oil red O staining the fat droplets as red. This blue part are the muscle. Here, this red part are the fat as well. Okay. This is the diagnostic criteria of ARVC, major criteria, minor criteria. You don't have to memorize, but just remember what are the features. They might come in the exam, right? What happens in the biopsy, what kind of arrhythmia is there, typical NSVT or VT with LBBB morphology and left superior axis. Hmm? Does anyone know how to localize ventricular arrhythmias? I will teach in the next class. So I am finished with this cardiomyopathies. I think I'll need to share my next slide. Mm, This one. Can everyone see the new slide? Yeah?
Yes, ma'am.
Yeah. So this is session 3, ACS and pericardial diseases. Today's objectives is only this much. ACS, ECGs of myocardial infarction, management and pericardial diseases. So, acute coronary syndrome, as everyone knows, it includes STEMI, NSTEMI, and unstable angina. STEMI is ST elevation with troponin rise. NSTEMI, no ST elevation but troponin rise. Unstable angina is ischemia without biomarker rise. So, in NSTEMI, there is partial occlusion. In STEMI, there is complete occlusion. Clinical features, typical chest pain. Lasting this 20 minutes is an important thing, sometimes comes in the question. Chest pain lasting for more than 20 minutes, radiating to arm and jaw, not relieved by rest, not trapezius. This is again one of the MCQs that used to come. It's important. Trapezius pain being referred to trapezius is usually pericardial, associated with diaphoresis, that is sweating, dyspnea, nausea, atypical symptoms seen in women, elderly, or diabetic patient. Diabetic patients, why? Why do we see atypical symptoms in diabetic patients?
You will not get pain in diabetic patient because
Yeah, why? Because of autonomic neuropathy.
okay, yeah.
Autonomic neuropathy. They have autonomic neuropathy in whole body. So they will have autonomic neuropathy in nerves connecting the heart as well. Okay. So no pain. So no typical symptoms. Pathophysiology is usually plaque rupture, platelet aggregation, thrombosis, myocardial ischemia because thrombosis cuts off the blood supply to the target myocardium. Other mechanisms are dynamic coronary obstruction, which is due to vasoconstriction or vasospasm, or microembolization. We'll come to it. This is a huge, what is this? This is the huge criteria, huge definition. Usually medicine people also has to memorize. This is the universal definition of myocardial infarction. You don't have to memorize, obviously, for MRCP. Just know that the absolute necessity for myocardial infarction is the rise of cardiac enzymes above 99% of the upper reference limit, okay, of cardiac troponins. There can be ECG changes, there may not be ECG changes, there can be symptoms, there may not be symptoms, etc. etc. There are usually 5 types of MI. Here are the 5 types. Type 1 is MI related to ischemia caused by acute atherothrombosis. This is the commonest one we know, which causes acute coronary syndrome, okay, coronary blockade and MI. Type 2 is secondary MI caused by, somebody is drawing something on here. Type 2 is secondary MI caused by either increased oxygen demand or decreased supply. That is, for example, in anemia, a patient who has severe hemorrhage will have acute anemia, acute decrease in oxygen supply to the myocardium. Even if there are minor blockages in the coronaries also, or there is increase in the heart's demand, they will sustain an MI. Those kind of MI is called a secondary MI or type 2 MI. Type 3 is MI associated with sudden death but occurring before blood sample could be collected or before the appearance of cardiac biomarkers in the blood. These are the autopsy MIs. Like after the person is dead, we go to do autopsy and pathologically we find a coronary obstruction, that is type 3 MI. Type 4 and 4A and B are procedure related. 4A is MI associated with PCI. 4B MI associated with stent thrombosis. Type 5 is MI associated with CABG. The value of rise of troponins is different. It's 5 times in PCI, 10 times in CABG. Just remember that much. You can go through the main big definition that will give you more clarity. Remember this ST elevation criteria, it needs to be more than 1 millimeter in all leads other than leads V2 to V3 where the following cut points apply. More than 2 millimeter in men more than 40 years, more than 2.5 millimeter in men less than 40 years, or more than 1.5 millimeter in women regardless of age. Why in men the criteria is higher? Because there is sometimes concave J point elevation in male patients even without early repolarization. It is a natural variant also called a male pattern. So their criteria is higher than women. ST depression, new horizontal ST depression of more than 0.5 millimeter in two contiguous leads, or T inversion more than 1 millimeter in two contiguous leads with prominent R wave or RS ratio of more than 1. So these are the different other types of mechanisms of MI. This is the typical atherosclerotic plaque thrombosis or plaque erosion or calcific nodule which causes thrombosis, and finally ACS. These are non-atherosclerotic causes. One is coronary vasospasm. One of the common causes, drug abuse like cocaine, can be genetic causes as well. Then second is spontaneous coronary artery dissection, which is also called SCAD. It is very common in young females. In young female, if the clinical scenario is given, there is no blockages in the coronary artery, but there is spiral or longitudinal tear in the coronary wall and false lumen formation. This is called SCAD, which is common in young females. Then there can be myocardial bridging. Myocardial bridging can be benign, completely benign, or even cause MI in very rare cases. Then there can be Takotsubo, which we talked about, sympathetic stimulation, catecholamine elevation, stunning of the myocardium. And there can be coronary artery embolism. Embolism means the clot is traveling from a different source. It can be left ventricle, it can be left atrium. Left atrium, say clot goes into the left ventricle, from there goes into the aorta. Instead of going into the main aorta, main lumen, it goes into one of the coronaries, which is the first branches of the aorta, and causes heart attack. That is also possible. possibility. Investigation, two investigations you have to know very well. One is the enzyme, cardiac enzymes, and another one is the ECG. Coronary angiograms, nobody is going to ask in these exams. Investigation, ECG, there has to be serial changes, cardiac biomarkers, troponin is preferred. Again, cardiac biomarker, there has to be either rise or fall in cardio biomarker. It cannot be a static level, then the diagnosis of MI will not be there. Echo, we see which territory of the heart is involved, whether anterior valve, inferior valve, and we also assess the LV function, how much the heart is pumping, because that leads to prognosis, whether the patient will develop heart failure, whether there are mechanical complications like MR or septal rupture, things like that. And then we go and do chest X-ray and cardiac MR, which are just ancillary investigation. They are not needed for diagnosis of MI. But always remember, the first investigation that picks up any kind of myocardial infarction is cardiac magnetic CMR, cardiac magnetic resonance. But it is impractical for patients coming with chest pain and you refer them for CMR, right? So, STEMI and STEMI unstable angina, we know ST elevation, troponin, and vessel occlusion. We just talked about it. This graph is important. There will be question, which is the first biomarker to rise in MI. There's the myoglobin and some CK isoforms. After myoglobin, there is CKMB. See, the myoglobin rises quickly and comes down to normal level within 1 day, actually within less than 12 hours. CKMB also normalizes. This is the detection level, this yellow dotted line. Comes within normal limit within 3 days. Troponin, on the other hand, it's very specific. It but it lasts for many days. At least 6 to 7 days. Sometimes it lasts for 4 to 6 weeks. So if we intervene, if there is a stenting done or a CABG done, the rise of the troponin, this graph will be taller. There will be more rise of troponin, but it will come down to normal level faster. So a patient who has revascularized after STEMI, their troponin level will come down to almost normal within maybe 2 weeks or so. Okay, but it is never guaranteed. Troponin may be high till 4 to 6 weeks. Remember that. So these are troponins. You have to know what troponins actually are. I am pretty sure everybody read about troponins in their physiology first year of MBBS. But these are the three types of troponin. Initially, especially in our government setup and everywhere, we used to do trop-T, troponin T. But more specific is troponin I. See, this is only released, like detection of troponin I is much more specific than troponin T in detection of myocardial infarction. Because troponin, and this is the troponin T, this can rise the following exercise as well. Troponin I assays have also been improved, and now the high sensitive troponins, we follow this pattern. Any level more than 0.04 nanogram per ml in high sensitive troponin I, that is a positive result for myocardial infarction. It can be detected as early as less than 2 hours. The initial old assays, non-specific troponin I assays, it can detect only after 4 to 6 hours, not before that. So these are the other causes. These are the other causes of rise in troponin. Myocardial damage in cardiac pathologies, myocardial damage in non-cardiac systemic pathologies, and false positive causes of increased troponins. Myocardial damage in cardiac pathologies include, apart from AMI, all kind of inflammation: endocarditis, myocarditis, pericarditis, cardiac arrhythmia, cardiomyopathies, drugs with direct cardiotoxic properties like chemotherapy, heart surgery, CABG, PCI, Takotsubo syndrome, and another very important thing is post resuscitation. A patient had cardiac arrest, you resuscitated, gave CPR, and then we check the troponin, it will almost always be elevated because there is cardiac injury. Myocardial damage in non-cardiac or systemic pathologies are heavy physical activity like marathon or stressful situations, systemic inflammatory reaction like sepsis. This is a very common call we get for cardiology referral from ICUs. This patient has high troponin, so this patient has myocardial infarction. It's not true. In sepsis and multi-organ failure, especially in chronic renal failure, troponin will be high. In pulmonary embolism, in CNS, severe disease of CNS like stroke or subarachnoid hemorrhage, and systemic hypoxia in a number of critical conditions, severe anemia, respiratory disorder, COVID-19, the troponin can be elevated. These are false positive cases, but always remember hemolysis is one cause in which there can be falsely positive troponins. Rheumatoid factor again is one of the cause which gives false positive results with various antibody assays. We will come to ECG localization. ECG localization of STEMI. So you can see in this diagram we are placing the electrodes around the heart, and we have drawn the coronary arteries. So if the LCX goes, it supplies the lateral ones. So the V5, V6, V7, V8, this will go off. They will show ST elevations. If LED is blocked, this is supplying the anterior wall. So we will see elevations in the V2, V3, V4, V5. If LMCA is blocked, there can be extensive elevations in the anterior and lateral leads, or there can be something else called the LMCA pattern. I'll come to that later. Now, if the RCA is blocked, see which leads are facing it, none of the chest leads. So there will be elevations in these two facing leads, lead 3 and lead 2. Apart from that, if we put the right ventricular leads, V4R, V5R, there will be ST elevations in them. So this is the localization chart. Everybody, I think most of you know mostly. In antral MI, there will be ST elevation in V1 to V6. In septal MI, there will be elevation in V1 to V4 and disappearance of septal Q in leads V5 to V6. V5 to V6 will probably not have any ST elevation. This all signifies LED occlusion. Lateral MI, there will be elevation in 1 AVL, C1 AVL, V5, V6 facing the lateral wall, and ST depression in inferior leads, which shows an LCX occlusion. Inferior MI will show 2 AVF and 3 elevations, usually caused by RC in 80% of cases, sometimes caused by LCX in 20% of cases, especially if the coronary circulation is either left dominant or co-dominant. Do you remember what is left dominant, what is co-dominant? I hope you do. Posterior MI is occlusion, more commonly occlusion of LCX, sometimes occlusion of RCA can also cause. Right ventricular MI will have elevations in V1 and V4R. It is very uncommon to have isolated right ventricular MI, usually always happens with inferior wall MI. 25% cases of inferior wall MI will have right ventricular MI, which is caused by RCA occlusion. Atrial MI is also mostly caused by RCA occlusion because atrial branches come from the right coronary artery. There are two other patterns, the high lateral wall MI, and of course, we talked about posterior MI already. High lateral wall MI, we'll come to it. So I'm just showing ECGs. Can you tell me which wall MI is this? Which vessel is occluded? This one? First one, just keep on typing or just unmute yourself, talk. I want discussion in this. It's so easy.
Anterior septal volume.
Anteroseptal wall MI. So which vessel blocked?
LED.
LED. Good. This one? This next one?
Anterior lateral volume.
Interior volume.
Yes.
Anterior lateral.
Yes, correct. This is also anteroval MI only, most likely LED occlusion, but these are early stages. There is tall T waves, tall peak T waves, and there is loss of R waves, and ST elevations are just starting to form, right? So this is quite evolved. This one is just starting evolving. Okay. Now this one, third one. Anyone?
Inferior wall MI.
Yes, it is inferior wall MI. It is inferior wall MI, but inferior wall, yeah. Tell me.
Is inferior posterior.
Yes, this is inferior wall MI. No, posterior wall is very unlikely to have been involved in this. Why? I'll come to that. In posterior wall, we just read in posterior wall MI, there will be ST depression in V1, V2, V3. There is a frank ST elevation in the inferior wall. So this is inferior wall MI, most likely caused by RCA, right coronary artery occlusion. But there are subtle increase in ST elevations in the anterior wall as well. There can be many explanations for it. The commonest in this case is a super dominant RCA. The RCA is so long that it goes and supplies the apex of the heart. Those kind of RCAs are called super dominant RCA. This one, fourth one. This one. This is
Inferior
also
posterior.
yes, correct. This is an inferior posterior wall MI. Inferior wall MI with ST depressions in the V1, V2, V3. Most likely posterior wall is involved. And you can see there are subtle elevations in V5, V6 as well. Okay, so we don't know. It might involve the LCX as well. We don't know. Only a coronary angiogram will tell you. So this one, anyone? This first one, left upper corner. Is it a STEMI to begin with? Is it a STEMI?
Non-ST elevation MI, non-cubable.
Yeah, you have to say it can be non-ST.
Can be a posterior MI.
Yes, correct, correct. Even a posterior wall MI is a STEMI. So you need to take the posterior wall ECG leads and then say whether it's a STEMI or not. So this is indeed a posterior wall MI. And this one? This one?
Lateral wall MI, lateral.
Yeah, but V5, V6, there is not much ST elevation, no?
ST elevation in L1 ABL and reciprocal depression in 2-3 ABF.
Very good, very, very nice. But there is not much elevation in V5, V6 and depression in 2-3 AVF. So it cannot be a lateral wall MI caused by LCX. LCX occlusion में तो inferior में भी जाता, right? So if there is ST elevation in only one and AVL, this is called a typical entity high lateral wall MI. It is not caused due to LCX occlusion. This is caused due to a diagonal occlusion. You remember diagonal was the large branch from LED, which supplies the upper part of the lateral wall of the left ventricle. This is typical feature of a high lateral wall MI. And this is your RVMI. These are the features of RVMI. Just remember the first one or two. ST elevation more than 1 millimeter in V4R. RVMI is almost always associated with inferior wall MI. This is the most important criteria. This one. Okay. Right ventricular MI. Can you tell me which vessel is occluded?
RCA, super dominant RCA. ST elevation in L3 is more than L2.
Very good. Very nice. Very nice. So this is an RCA occlusion in inferior wall MI. Very simple. What is Garbosa criteria?
The criteria for LBH, left ventricular hypertrophy.
No.
Left bundle branch block. Left bundle branch block.
Yes.
ST elevation
Left
in left bundle branch block.
True. Diagnosing a STEMI in left bundle branch block or paced rhythm. This is Garbosa criteria. This here is the classical Garbosa criteria, which gives three phenotypes points. Concordant ST elevation of more than 1 millimeter. There is 5 points maximum. ST depression of more than 1 millimeter in V1 to V3. It is 3 points. And discordant ST elevation. Discordant meaning the QRS vector is mostly negative, but there is discordant ST elevation. Opposite the QRS vector, there is elevation of more than 5 millimeter. It is given 2 points. In classical Garbosa, if the total point is 3 or more, then there is high likelihood of MI, STEMI. This is the modified Garbosa criteria. It retains this number 1 and number 2 points are the same. For number 3, it is this fixed 5 millimeter is changed into ST elevation ratio with the height of S wave more than 25%. So in modified Garbosa, there is no point system, only yes, no, yes, no, yes, no. If any of the points is yes, then there is STEMI equivalent. It is called STEMI equivalent in LBPP. KILIP class, NYHA classification, I have put it here because you need to remember NYHA classification is more relevant in heart failure, but all cardiac symptoms are included in NYHA classification except for there are typical 7 cardiac symptoms: breathlessness, palpitation, chest pain, etc. So only syncope is not included in NYHA. Okay, syncope is not included in NYHA. Rest all the symptoms can be described by NYHA. This KILIP classification is very important, which relates to hospital mortality. KILIPS and Forrester classification, this you may or may not remember, but KILIP classification you need to remember, and you need to classify in any clinical scenario. Questions will also come with KILIP classification. Class 1 is no congestion, class 2 is S3 and basal rails, means the patient is in failure. Class 3 is acute pulmonary edema, means not only signs of failure but severe dyspnea, the patient needs additional oxygen or ventilatory support, etc. And number 4 is cardiogenic shock. These are the hospital mortalities. When initially described, nowadays even cardiogenic shock patients are saved, like much more than 19% patients are saved. These two scores are also to be remembered. Please go through, because they may ask a question which is not included in the TIMI score or GRACE score. GRACE not so important, TIMI always remember. And remember that GRACE score includes more lab investigations. Okay, like elevated cardiac markers, all these things, serum creatinine, all these things, compared to TIMI score, which is mostly clinical, history and clinical based. GRACE score usually performs better than TIMI and used in more studies. This is the mortality data of score. You have to know what is called low risk. In GRACE, less than 108 is low risk, 109 to 140 is moderate risk, more than 140 is high risk. GRACE you do not calculate by hand. There are calculators, online calculators, which will give you the GRACE score and corresponding mortalities. Now coming to complications of ACS and MI, there are these are the major types of complication: mechanical, electrical, inflammatory, ischemic, and embolic. Mechanical complications will give you a lot of questions and MCQs in MRCP. Cardiogenic shock, free wall rupture, ventricular septal rupture, ventricular aneurysm, and acute mitral regurgitation. Electrical will be arrhythmias, AV blocks, and fascicular blocks. Arrhythmias, what can be there? There can be reperfusion arrhythmia, one very common and is benign. Number two, there can be ventricular tachycardias from the scar that has formed in the LV. These are very, malignant. Patient may die from ventricular tachycardia and fibrillation. AV block or atrioventricular blocks are very common in which kind of myocardial infarction? Mostly in
Inferior volume. Inferior
inferior
volume.
volume. If the RCA is blocked, we read about it, right? And
Yeah.
fascicular blocks, LBBB or fascicular blocks are left bundle branch block or right bundle branch block or left anterior fascicular or posterior fascicular blocks. These are more common. Fascicular blocks are more common in LAD occlusion, anterior volumi, because these are Purkinje fibers are mostly supplied by the LAD. Inflammatory Dressler syndrome. What is Dressler syndrome? It's acute pericarditis, pericardial kind of pain, which is actually a reactive pericarditis after myocardial infarction. Okay, mostly self-limiting. Ischemic, post-infarction angina, embolic, mural thrombosis, and systemic embolism. We just talked about it. If the LV becomes weak, there is stasis of the blood, and that clot may go into your brain vessels, cause a stroke, can go into eye vessels, cause CRAO, can go into your renals, can cause renal shutdown, can cause mesenteric occlusion, can again cause a heart attack, can block arteries of the legs as well. This is the mechanical complications in acute MI. All these are very important clinical scenario. Acute LV or RV dysfunction will present as LV failure or RV failure. Ventricular free wall rupture, usually this patient they have mortality exceeding 90 to 95%. Ventricular free wall rupture, most of this patient will die. There will be features of tamponade or sudden VT and collapse with hypotension. And on echo, we can see huge pericardial effusion, which is formed by the blood, like hemopericardium. There will be fibrinous echo densities. The blood is not as thin as normal pericardial effusion, right? So we can see fibrinous strands and everything, and there will be sudden cardiac collapse. Ventricular septal rupture is slightly more benign than ventricular free wall rupture. Clinically, there will be murmur. If a patient with myocardial infarction comes and has systolic murmur, there can be sudden systolic murmur. There can be two possibilities. One is ventricular septal rupture, one is ischemic MR due to rupture of the chorditendinae. The ventricular septal rupture, there won't, it will be more loud. The murmur will be very loud. The MR murmur will be very soft, but MR patients will have more pulmonary edema. Ventricular septal rupture, the sound will be more, but the patient will be more stable. In MR, the sound will be less, but the patient will be sicker. Both are indications for cardiovascular CTVS referral. The surgeons must take up the patient and repair it. Surgical repair is one of the ways of treating them. Another way of treating ventricular septal rupture is a device closure, which is done in a minority of cases, in very selective cases. Okay, always remember ventricular septal rupture in inferior wall MI is worse than in anterior wall MI. Okay, because of ventricular septal rupture, it acts as a VSD. So there will be more shunting of the blood in the right heart and into the pulmonary tree. There will be development of pulmonary hypertension. And MR, suddenly there will be regurgitant jet that goes into the left atrium and into the pulmonary tree, cause pulmonary edema and severe dyspnea. This patient will come with. Ventricular pseudoaneurysm may form, like there will be an outpouching. This is actually ventricular aneurysm is a true outpouching. Ventricular pseudoaneurysm is a rupture which has been sealed with a clot. So pseudoaneurysm is much more riskier than a ventricular aneurysm. Ventricular aneurysm, what can it result into? Again, stasis of blood, formation of LV clot. That LV clot may go and cause systemic thromboembolisms. Management of ACS, immediate management is morphine, oxygen, nitrates. We have to calm the patient down, relieve the pain, and decrease ischemic burden. So, morphine, oxygen, calming them down, pain relief, aspirin, beta blocker, ACI, statin, and heparin. Very easy. There are mnemonics to remember, but I think it's quite easy to remember as it is. The the definitive treatment is either opening the vessel by primary PCI or thrombolysis. Primary PCI is preferred if available within 120 minutes. Thrombolysis, if PCI is delayed more than 120 minutes, then we will go for thrombolysis or fibrinolysis. So therapeutic goals are relieve ischemic pain, restore coronary perfusion, prevent further thrombosis, reduce myocardial workload, and long term limit remodeling and recurrence so that LV dysfunction doesn't happen, patient doesn't go into long term heart failure. Main drug classes are antiplatelets, anticoagulants, anti-ischemic agents, reperfusion, and secondary prevention drugs. This is a nice guideline. It's, you may think this is a lot of things are written, but it's a huge guideline. I just picked up one page from it, just one picture from it, because almost every line is important. Fibrinolysis offer if presenting within 12 hours and PCI not possible. Always give an antithrombin with fibrinolysis. What is that? Usually we give heparin or low molecular weight heparin. For ECG 60 to 90 minutes after fibrinolysis. Always remember, in patients of renal dysfunction, we don't use low molecular weight heparin. We only use plain heparin, unfractionated heparin. Offer ticagrelor with aspirin unless high bleeding risk. Previously, we always used to say aspirin and clopidogrel. But now all the guidelines say give ticagrelor unless during fibrinolysis. whether you want to take the patient for PCI or you don't want to do anything, fibrinolysis or PCI, like only conservative management. In both cases, give ticagrelor. Only do not give ticagrelor if the patient has high bleeding risk or with fibrinolysis. After 24 hours of fibrinolysis, also you can start with ticagrelor. Ticagrelor, one of the common complaints that the patient do is dyspnea, but you don't need to be worried about it. It has a separate mechanism. It doesn't cause heart failure. So do not repeat fibrinolysis even if the patient is having chest pain and there is a failed fibrinolysis, then patient needs to be taken up for PCI. PCI is percutaneous coronary intervention, right? Do an echo, assess left ventricular function, angiography with follow-on primary PCI. If within 12 hours of symptom and PCI can be done within 120 minutes, which can be done in most of the cath labs, we should take the patient for PCI. Otherwise, thrombolysis. Then drug therapy, usually prasugrel or ticagrelor is preferred. Prasugrel is contraindicated or not preferred for people above 75 years or very thin people or people with history of stroke. Think of a very old man who is very thin and had a history of stroke. This person cannot be given prasugrel. Everybody else can be given. It's a very efficacious drug. Stenting and revascularization, stenting only if needed. We just need to re-establish the flow. Thrombolysis, the mechanism is activating plasminogen. This plasmin goes and lyses the fibrin clot. Aspirin plus fibrinolytic agents reduces mortality synergistically. Indications STEMI if PCI delay more than 120 minutes. These are the three most common thrombolytics that we use: streptokinase, tenecteplase, and alteplase. Actually, the commonest used in tertiary setup is tenecteplase. Streptokinase is most widely used even in places where people cannot afford because it is very cheap. The reperfusion rate in streptokinase is only 50% and fibrin specificity is low. So there are more chances of off-target bleeding. What is off-target bleeding? Like we are giving streptokinase, there is bleeding in the gut, there is bleeding from the gums, there is hematuria. This is off target bleeding, which is much less common in tenecteplase or alteplase. These are the dosage I have included here so that you can revise before exams. The common dosages you need to remember: one is this alteplase dose. Okay, this is actually very easy to remember. It's very easy. Maximum dose is 100 milligram and one bolus and then infusion is given both in stroke and myocardial infarction. Streptokinase dose is straightforward, 1.5 million units. Tenecteplase dose is also quite straightforward. Urokinase, we only give in acute pulmonary thromboembolism, but there is some off-label use in STEMI as well. In really poor patients who cannot afford all these alteplase, retiplase, and all that, urokinase can be given if streptokinase was given within 6 months, because there is streptokinase also causes development of antibodies very fast. These are absolute and relative contraindications of thrombolysis. You only need to remember the absolute contraindications, like hemorrhagic stroke ever, ischemic stroke in preceding 6 months, CNS damage or neoplasm, recent major trauma or surgery or head injury in 3 weeks, GI bleeding in the last 1 month, known bleeding disorder or aortic dissection. Because these will come as your clinical questions. This is important: ischemic stroke within 3 months, except acute ischemic stroke within 4.5 hours. A patient comes with acute dense ischemic stroke and AMI within 4.5 hours. What is the thrombolytic agent you will use? I'll be happy if somebody knows the exact agent that is advised. We'll move on to the next slide. If anybody remembers, please write it down. Antiplatelets, aspirin, it's an irreversible COX-1 inhibitor, decreases thromboxane generation and hence decreases platelet aggregation. Doses 150 to 300 milligram chewed loading. In all practical purposes, we give 300 milligram to chew as soon as patient is detected to have a myocardial infarction. Decreases mortality by 23%. Contraindications are active bleeding, severe asthma, and peptic ulcer. Always give immediately. The other P2Y12 inhibitors are clopidogrel, prasugrel, and ticagrelor. These only clopidogrel is irreversible. Both of these are reversible inhibitors but very efficacious. IV antiplatelet, I hope everybody knows there is only one available in the market, that is Cangrelor, which has a rapid onset and offset. So patients with really high bleeding risk, we can use this antiplatelets just during the procedure to prevent stent thrombosis and all, and then stop it after the procedure is done. Cangrelor. These are the sites of action. You can see aspirin acts as thromboxane generation, and Vorapaxar. These are rare when we don't use. P2Y12 inhibitors or ADP receptor antagonists, thienopyridines are ticlopidine, clopidogrel, prasugrel. Ticlopidine is not used anymore. Reversible inhibitors are ticagrelor, cangrelor. GP2B3A receptor inhibitors are abciximab, tirofiban, eptifibatide. They are not routinely used in myocardial infarction. They are mostly used in during PCI support and sometimes in NSTEMI. PCI support is the commonest use if there is heavy thrombus load. If there is no flow, we cannot put the stent. There is too many thrombus. We add an eptifibatide or tirofiban to help us. These are the, again, I'm not going through the list. We will come to anticoagulants. Just give me, yeah, we have around 5 plus 5 minutes. We started late. We have 10 minutes. We'll probably finish up today. Anticoagulants, unfractionated heparin, enoxaparin is LMWH. As I told you, always remember in renal dysfunction, we cannot give LMWH. We have to give unfractionated heparin, but it is unfractionated heparin is less specific, inhibits both activated factor 2 and factor 10. And another problematic thing about unfractionated heparin that may happen in some of the patient is heparin induced thrombocytopenia. I want everybody to go back and please read HIT, that is heparin induced thrombocytopenia. There are two types and there is a clear definition. It can be even asked in your third stage, that is in PACES also. They can ask about heparin induced thrombocytopenia. Fondaparinux is a selective 10A inhibitors, fewer bleeds in patients who are intolerant or in whom heparin is contraindicated. We can use fondaparinux. Bivalirudin again is one of the direct thrombin inhibitor which we can use in heparin induced thrombocytopenia. Used with fibrinolytics, always used in NSTEMI or unstable angina. Used during PCI. In HIT, bivalirudin preferred. Others are argotroban or fondaparinux. Okay. So, what are the other drugs? What are the mechanism of action? The anti-ischemic drugs used in ACS are nitrates, commonly oral and IV NTG. You can give other oral short-acting nitrates as well. Long-acting nitrates are not preferred. Why? Because tolerance development may be there. So they cause venodilatation, which causes decrease in the preload of the heart, decrease oxygen demand. Decrease oxygen demand is better matching of the oxygen supply, and so there will be less increase in the ischemic area of the heart. Avoid if the patient is hypotensive or on sildenafil. In RVMI, in right ventricular MI also we avoid it. Why? Right ventricle, we had talked about it, Frank Sterling law. Right ventricle is very much, it's not a very good pumping, it doesn't have a very good pumping mechanism as LV. So it depends a lot on the preload for its cardiac output. So if we decrease the preload, then in right ventricular MI already the RV is weak. We are decreasing the preload, then we will not have any RV output at all. So nitrates are contraindicated in RVMI. Concerns are headache, flushing, and tolerance. Beta blockers, CMB. What is CMB? The common three beta blockers used in MI: carvedilol, metoprolol, bisoprolol. All three can be used. Metoprolol, usually we use the short-acting ones during the acute stage. Decreases heart rate and contractility, decreases oxygen demand. Start within 24 hours if there is no shock or bradycardia. In first 24 hours, it reduces arrhythmia risk and reinfarction. Calcium channel blockers are not used in ACS at all. I have just kept it here to remind that don't use calcium channel blockers. It is usually only used in Prinzmetal's angina where beta blocker cannot be given. Morphine is only for decreasing anxiety and decreasing pain. 2 to 4 milligram intravenously, repeated at 5 to 10 minute intervals. It gives analgesia and causes venodilatation. But in patients who are already, say, hypertensive, who are drowsy, who has severe respiratory distress, in those patients, we should not be giving morphine as it decreases the respiratory drive. Secondary prevention post ACS. These are the other drugs we have talked in detail during the heart failure discussion. AC inhibitors also needs to be started within 24 hours for best outcome. Statin needs to be started immediately, and statins, which are antilipid drugs, the main action during acute coronary syndrome is their anti-inflammatory or the pleiotropic effects. They stabilize the plaque. They do not immediately lower the LDL. They stabilize the plaque and prevents further ischemia, further formation of clot. Monitoring of LFT and myalgia symptoms needs to be done. Aldosterone antagonist eplerenone is only started if the ejection fraction is less than 40 or there are signs of heart failure. And long term, there should be smoking cessation, BP and glucose control, of course. This is a summary of lipid lowering therapy, anti-thrombotic therapy, anti-inflammatory. Till now, in guidelines, no anti-inflammatory therapy is advised. Some studies suggest colchicine can be beneficial, but it is not there in the guidelines. Lipid lowering therapy, one has to remember LDL cholesterol has to be less than 1.4 millimole per liter in 4 to 6 weeks. If it is not reached target, then ezetimibe needs to be added, or if even then it is not target is not reached, then PCSK9 inhibitors has to be added. Please name some PCSK9 inhibitors. Anyone? PCSK9 inhibitors, anyone? If people have slept, huh? Okay, the long term effects, the long term. Have you never used PCSK9 inhibitors? Any one of you?
Evolicum.
Very good. Evalucumab and alirocumab, right? Okay, lifestyle modification are long term goals like rehabilitation, dietary guidance, smoking cessation. This is a chart which shows how long one should take DAPTs. Always remember, after AMI, the classical teaching is to give DAPT or dual antiplatelets for 1 year at least. In higher bleeding risk, you can give as short as for 1 month. In higher ischemic risk, you can give DAPT for longer than 12 months. Read this chart. Even if I read it out right now, you won't be remembering. Always remember, in any stenting or PCI, ticagrelor or prasugrel is preferred, but in higher bleeding risk, clopidogrel has to be given. And if the patient has another indication of anticoagulation, say a patient is having AMI, but patient was already taking some anticoagulation due to atrial fibrillation or unprovoked DVT and all these things. In those cases, you need to continue anticoagulation for at least for a week to 1 month, depending on the bleeding or ischemic risk. Choice of timing of management strategy in NSTEMI. Only this first part is important. Immediate invasive strategy has to be done, that is within 2 hours, in cases of cardiogenic shock, symptoms of heart failure or worsening mitral regurgitation, acute pulmonary edema, refractory angina in spite of all medications, hemodynamic or electrical instability. Hemodynamic instability is patient is in shock or patient already cardiac arrest revived, and electrical instability is sustained VT which is not going which is not settling down with medications or DC cardioversion. Revascularization, PCI, preferred for single or double vessel or culprit lesion. Heparin or GP2B3A inhibitors for radial access. These are all nice guidelines, okay? Heparin is for radial access, they say. Bivalirudin is for femoral access, they say. In India, we use only heparin only. In shock, if the patient is in shock, the BP is low, then only go for culprit vessel. The culprit vessel that has caused the STEMI, only revascularize, stent that vessel. If no shock is there, then complete revascularization. All significant blockages have to be treated. If stent is used, obviously drug-eluting stent has to be used. Thrombus aspiration should be considered. Another important thing about DAPT, which is different in UK guidelines than ACC guidelines. UK guidelines, NICE guidelines still say when dual antiplatelet duration is reached and you want to shift to single antiplatelet, you continue with aspirin lifelong. But in ACC and AHA guidelines, they are now preferring a P2Y12 inhibitor, single antiplatelet with either clopidogrel or ticagrelor. CABG is indicated for left main stem or triple vessel disease. Very rarely patients are sent after ACS. In diabetes or poor LV function, and in mechanical complication, obviously you will have to send like ventricular septal rupture or acute MR. Those cannot be corrected by transcutaneous routes. Types of CABG, if somebody is interested, I will elaborate more. Single, double, triple, quadruple. It refers to the number of grafts that are used to bypass the blockages. Minimally invasive, in which we avoid complete sternotomy, and off pump, where your heart lung pump is not used. These are only possible in single or sometimes in double grafts. When we are working for 4 hours, 5 hours, and we need extensive dissections, it won't be possible to use off pump, though like CTVS people are improving day by day. Grafts that are used in CABG, this is also an MCQ question that had come long back. Commonest is Lima, then Rima. What is Lima? Left internal mammary artery. Rima is right internal mammary artery, radial artery, saphenous vein, and gastroepiploic artery. Arterial grafts always last better than the venous grafts. Coming to pericardial diseases, should I continue or next class? It's just a few more slides, if you can bear with me. So acute pericarditis, yeah, somebody has written something. Okay. Acute pericarditis is inflammation of the pericardium, of both the pericardium, the serous and the fibrous layers. Common causes are viral, Coxsackie or echovirus. Post-MI, we just discussed, is Dressler syndrome, usually self-limiting. Bacterial, tuberculosis or pneumococcal. Autoimmune, SLE or rheumatoid arthritis. Other causes are uremia, that is CKD patient, neoplastic, radiation or trauma. Clinical features are sharp, pleuritic type of chest pain, not the anginal type of chest pain, relieved by sitting forward, leaning forward. Friction rub is a common clinical is not a common but very diagnostic clinical features, which is usually triphasic, based hard at the left sternal edge. Low grade fever and dyspnea might be present. Investigation, ECG, this question will come. What is the ECG finding? There is diffuse ST elevation, which are concave upwards, and concomitant there is PR depression. See, the PR are lower than the rest of the isoelectric line with no reciprocal changes. Echocardiography is usually non-diagnostic. Sometimes effusion may be present. ESR, CRP will be elevated. Troponin will be elevated. Only the ECG is diagnostic. The pain is very typical, and you have to rule out AMI, nothing else to do. Management is, first line is NSAIDs, which is, it can be ibuprofen or aspirin, plus colchicine. Colchicine dose is very easy, 0.5 milligram for less than 70 kilos, 0.5 milligram twice daily for more than 70 kilos of weight. If refractory, corticosteroids needs to be started. Underlying cause maybe should be treated like uremia and malignancy. Avoid anticoagulation because there is risk of hemopericardium. Okay, the effusion, there will be bleeding into the pericardial effusion. Avoid anticoagulation as well as wrongful fibrinolysis, thrombolysis. Many a times it happens in hospitals. Chronic constrictive pericarditis is a topic from which many MCQs can come. There is chronic fibrosis and thickening of the pericardium. So the pericardium acts like a non-stretchable bag, and there is impaired diastolic filling. So where else did we learn impaired diastolic filling? In restrictive cardiomyopathy, right? It was the same mechanism, impaired diastolic filling. But this is because of the non-stretchable, thickened fibrotic pericardium surrounding the heart. Etiology is post-tuberculous, common in developing country. In our country is the most common cause. Others are post-cardiac surgery or radiation, connective tissue disorders, post-viral or post-hemopericardium. Pathophysiology is rigid pericardium, early rapid diastolic filling, followed by abrupt stops. This square root sign is actually seen in hemodynamic monitoring of the right ventricular pressure waveform. I will show you how it looks. Clinical features, again, it will be right heart failure sign, increased JVP, ascites, hepatomegaly, edema, exactly like restrictive cardiomyopathy. There will be Kushmal sign, JVP rise with inspiration, pericardial knock, that is early diastolic sound. With early rapid diastolic filling, suddenly this fibrotic pericardium, it reaches its maximum limit of expansion. At that time, there is tuck, one knock, that the heart is, this is it, it cannot expand anymore. It hits against the rigid pericardium, and that forms the pericardial knock. There can be fatigue and dyspnea in the patient. This is the square root sign. This is the RV pressure curve. Usually, it is more undulating. It rises slowly as there is rapid filling of blood when the AV valve open, tricuspid valve open. But here, see, in the right atrium, there is filling, suddenly it stops because it cannot accommodate any more blood. So this is the square root sign seen in constrictive pericarditis. CT MRI, there is pericardial thickening of more than 4 millimeter. In cardiac catheterization, there is equalization of the diastolic pressures of RV and LV because no particular ventricle is involved. The whole pericardium is involved. Both the diastolic pressure equalizes. Usually, RV pressures are lower than the LV pressures, even in diastole. But in CCP, there is equalization. Management, medical, diuretics for symptom relief, and definitive is surgical cardiectomy. It's very easy. The CTVS surgeons go in, they just cut out some portion of the pericardium to relieve the ventricles so that the ventricles can contract and relax easily. So what is Beck's triad? Beck's triad is seen in which disease? Beck's triad is a classical finding of
Tamponade.
very good, very good. It's pericardial tamponade. So, pericardial tamponade is accumulation of pericardial fluid under pressure, which causes impaired ventricular filling. So, this fluid can be anything. It can be effusion, it can be hemopericardium, it can be pneumopericardium, air in the pericardial sac. Anything that impairs the ventricular filling due to presence of a fluid in the pericardial cavity, which is under pressure. Causes are malignancy, trauma, uremia, pericarditis, and aortic dissection and rupture. Beck's triad is hypertension, elevated JVP, and muffled heart sounds. Other findings are pulsus paradoxus, more than 10 millimeter fall in systolic BP on inspiration, tachycardia, and dyspnea. This is your echo finding, right? You can see this is the heart, some black thing around the heart, surrounding all around. This is fluid around the heart, this pericardial effusion. And how do you understand tamponade? The RA and RV, they will collapse. Normally in effusions, they will not collapse till tamponade physiology is developed. If they are collapsing, then it is tamponade. It's a cardiac emergency. You need to call the cardiologist, and pericardiocentesis needs to be done. In echo, diastolic collapse of RARV, ECG, low voltage QRS, electrical alternates. Can you see this ECG? There is alternate amplitude of the QRS. This is high, this is low, this is high, this is low. This is called electrical alternates, typically seen in cardiac tamponade, also seen in some supraventricular tachycardia, but anyway, typically seen in cardiac tamponade. Chest X-ray, enlarged cardiac shadows, and there can be other stigmata of disease. Can be signs of heart failure, then can be lung nodules which will suggest malignancy, etc. But heart will look globular like this. Management is emergency pericardiocentesis, volume expansion temporarily. Some fluids need to be given because all fluids are getting collected in the pericardial cavity. Heart does not have enough volume to expand. So you need to start a normal saline and then prepare the patient for pericardiocentesis. This chart is also important. This is the last slide. The difference between constrictive pericarditis and restrictive cardiomyopathy, because they present with the similar clinical features of right ventricular failure. There is difference in pathology, etiology. Clinical features will almost be same. Raised and prominent raised JVP, Kushmal signs will be present, but pericardial knock is present or absent. In echo, it is telltale sign. In constrictive pericarditis, there will be septal bounce, thick pericardium, and in RCM, the pericardium will be completely normal. There will be thickening of the LV wall, biatrial enlargement, septal, intraatrial, septal thickening. We just talked about it. So, echo, MRI, catheterization, these are very important to distinguish the two. Sometimes AMRI need to be done, which will clearly show pericardial thickening in CCP and myocardial infiltration in RCM. Treatment is pericardectomy for CCP, and RCM is obviously symptomatic and treating underlying causes. Further reading, landmark trials, if you're interested, go through it. I'm sure medicine people must have read it already. Peripheral vascular disease and CLI. What is CLI? Critical limb ischemia. Please read about it. If we get time in the last session, we will talk about it. Next class, we will talk aortic diseases, venous diseases, and brady and tachyarrhythmia. Thank you. I will stop sharing. Does anyone have any questions? Or if you do, I had given you my email ID. You can mail me as well. I will reply. And if you want anything extra to be included in the next few sessions, do let me know. I will be mailing all these 3 slides to the coordinator, and they will be mailing to your individual mails if possible, if I understand correctly. Yeah. Thank you so much for your patient attention. I'll see you for the next session. Bye.
Thank you, ma'am. It was a
Thank you.
wonderful session. We'll be scheduling the next session soon. Thank you.